physiology stuff that is on the slides. I'm gonna make sure I don't miss anything. Okay. So cardiac conduction. This picture is what you need to know. We've already talked about the primary pacemaker, the SA node, right? 60 to 100 times per minute, correct? The AV node, the intrinsic firing rate of the AV node is what?
50. That's what it said.
Yeah, I know. It said 50 on the video, but I want you to remember about 40 to 60. Okay? And then the intrinsic firing rate of the ventricles are less than 40, right? So we want to look at that, but we have three different cells that we're talking about. We're talking about pacemaker cells, which that comes from the SA node, the AV node, and the ventricles, okay, because they all have intrinsic firing rates or depolarization rates in case something doesn't happen. So we have pacemaker cells. We have conducting cells, which is sort of that yellow line that in here. These would be conducting cells, okay, that are made up of here. There's no actin and myosin in there, so they won't contract. They conduct. Okay, so pacemaker cells set the pace. Conducting cells conduct the electrical impulses through there to the cardiac tissue, which is made up of contracting cells. Okay, and that's what we want the heart to do, obviously, right? Contract. So the yellow part would be, if you were to look at a heart, a real heart, you could pick this out if you knew what you were looking for, because these would be discolored. They'll be different color because they don't have any. They don't have any actin and myosin, so there's blood flow there, but there's not like in the cardiac tissue. Okay, then you would have, in the same sense, this conducting. Then you would have the pacemaker cells up here, which you could find, like I said, if you knew what you were looking for, you could find the SA node. You'd have to dissect it out, and then you could find these electrical pathways into the contracting cells. So what this represents, this big white part here, is this impassable tissue for contracting cells. This is the sort of the avenues that the conducting cells run down. So almost, if you could picture putting wire and pipe, so they don't touch anything else, that's sort of what this does. That way that these contracting cells here won't touch the atrium. All right? So these cells that are in this left ventricle won't touch the atrium. If they did, then they would contract, right? Because what happens is, I drew over here, you have the same sort of drawing. I think mine's better, right? But, no, just personal opinion. But you have essentially all these cells sort of laying on top of each other. You have the pacemaker cell up here, and then the conducting cells, and they're all just sort of stacked. They're not little wires, they're cells. And they're all just sort of packed together, okay? And then these contracting cells, a layer of them, touch those conducting cells, okay? And once that depolarizes, then it conducts over to, the signal conducts over to the conducting cell. Does that make sense? Okay, so when one cell depolarizes, they all depolarize. That's why they sort of touch each other. And I've got a little video I'll show later. It's off the Facebook deal where you see the heart contracting, and you can actually see the sort of the flow of electricity running through it. Now it's all going to conduct at essentially the same time. It's not exactly the same time, but essentially the same time, because it's really fast. So when they depolarize, it's real fast, so you can't really, it's not like, strange word means here. Syncytium. Yeah.
How do you spell it either?
Well, This is not mine. I can't take credit for the spelling or misspelling. But
did you notice how he's
what this means is that this has one big cytoplasm. Okay? As the electrical current sees it, it sees the entire heart. You know, like if it's down here at the Purkinje fibers, it sees those cells as one. It doesn't see them as a gazillion different cells. It sees them as one cell or one cytoplasm, so they're going to contract essentially at the same time. Okay? However you say that, that's what that is. And it propagates down through here, and then once they, because they're all sort of touching, it would just be like us. If we all physically came in contact with each other, okay, and I had electricity, and I shocked one of you, whoever was at first, everybody would get shocked. And it would almost seem at the same time, because the speed of electricity is really fast, and the speed of this depolarization is really fast, so it would all contract at the same time. That's really the only thing that it's saying, okay? That with this, it's saying that, hey, these cells are all going to contract at the same time, but I want you to give a picture of it as they're laying over each other, okay? They're sort of all mixed in together, all right, in the heart. Okay? So we've talked about this, the AV node delay. The AV node delay is so we can have proper function of the heart, refilling time, right? We have proper refilling time. If not, then as soon as the SA node, the primary pacemaker, depolarizes, it would send that signal down. If the SA node wasn't there, it would send it straight down to the ventricles, and the heart wouldn't have any refilling time at all. Okay? And this is what we looked at with Karina a little bit here with these action potentials. You'll need to know these different phases for sure for the exam. Phase 0 is this fast. If you look here, remember this is the green one here is a nerve cell, right? That's that electrotonic potential, and the red one is the action potential. So phase 0 is you have a resting, and he's calling it a negative 90 millivolts. So you have negative 90 here is a resting potential. Okay, once this process starts, there's a neurotransmitter that stimulates it. Okay, so once this process sort of starts in the heart, it's automaticity. It's automatic. It starts up. It has even though the heart has sympathetic nerves in it. Okay, we'll break that down a little bit. So you have this rapid influx of sodium, right, in phase 0. Phase 1, which is right here at the top, a fast influx of calcium. And we want to say, hey, what's fast and slow, right? So I wrote it down. It has to come down later anyway. I wrote it down. Depolarization, okay? So when it depolarizes, fast would be 0.075. That's depolarizing, okay? And repolarization takes place in 0.3 seconds. And these are in seconds, okay? So fast would equal the 0.75, and essentially the slow would be around somewhere between 0.15 to 3. Okay, so this would be slow because this is the repolarization. So now we have sort of a definition of what's fast and what's slow. So you have now you have this part here. This is where the calcium comes in. See, in the nerve cell, no calcium, just a rapid influx of sodium and a rapid exflux of potassium. So sodium comes in, potassium goes out, right? boom, very quick contraction. Over here you have phase 2 and 3, which is sort of combined right here in this slope. 2 and 3 is a slow calcium influx, which is going to make this potential longer, that potential longer here. Remember, we need that for proper cardiac function. We need that slow sort of potential, because if we flip back here, that has to run up. This action potential, this signal, has to run up the ventricle for it to contract, right? So there's a distance here. If you were to continue these yellow lines up here, which they would, there'd be a distance, okay? So this dissipates very fast, so it's not good for covering distance, okay? So the heart has to have the calcium influx here, which causes this slope, in order for it to send the signal up the ventricles and form a proper contraction of the heart, right? Does that make sense? And then we're back down here to phase 4 in a resting potential. We're back down to resting, and this starts over and over and over again, very, very, very fast. And we'll talk later about problems with calcium. Matter of fact, when we get into EKG, we'll talk about this calcium channel blocker in atrial fib that we're going to use. And so the 4 phases starting at 0, it's a little, well, I guess there'd be 5. And the why. Why do we need the calcium? Where does the calcium come from? Y'all remember that from the other lecture?
The ER thing, the sarcoplasmic reticulum.
Right, and reabsorb it, okay? And if we were to have a calcium blocker, that takes place inside the cell, correct? So we have a calcium channel blocker. We're blocking those channels where that where that calcium comes into, right? If we don't have the calcium, if we block some of those channels, we can't block them all, right? We wouldn't have what? Yeah, right. We wouldn't have a contraction. We wouldn't have a heartbeat. Okay, so we don't block all the channels, block some of them. So if we block some of the channels, then we're going to decrease contraction, correct? Which would decrease what?
Cardiac output.
Well, yeah, in the end, a little bit, but
Stroke relief?
I didn't tell you enough here, huh?
What'd you say?
We'll decrease rate. We give this with the rate problem, okay? So we're going to decrease the rate there, all right? And then this is sort of the same drawing here, going back through there, and it sort of shows how it just goes over and over and over, right? So we have that action potential that open and closes these gates, open and close the gates, open and close the gates, and it continues to do that, or we wouldn't have proper cardiac function. So it opens and closes the gates, all right, with the sodium, potassium, and calcium influx and how it goes in and out to maintain. I think it's good there. All right, EKG, we've already done this, right? We've already talked about this in the EKG portion. So that's really all I want you to know is, lead 2 is the most popular one. Lead 2 is going to make all the QRS complexes upright, and it's easy to look at. Lead 1, not so much. It makes the QRS complexes negative. So the QRS complexes in lead 1 would be below the isoelectric line. The rest of it, I'm not too concerned about, okay? This just shows you the different, the electrical pathways, but I want you to be concerned that, or know that lead 2 is the most common. There are 3 leads, okay, which give us different electrical views of the heart. Okay, that's all they do, is they give us different electrical views of the heart. A 12 lead gives us different electrical views of the heart, right? when we talk EKG, when we're talking our 4-lead or 3-lead EKG, remember that is a monitor quality, a monitor. All you're doing is monitor, right? You're watching it. You're watching the electrical activity. On a 12-lead, because you have more leads, plus the speed of the paper, it becomes a diagnostic quality. So you would diagnose off of a 12-lead. A 3 or 4-lead, you would just monitor. Okay? There's certain reasons why we have tachycardias, certain reasons why we have bradycardias. Okay? In EKG interpretation, not so much to figure out, right? That's not the part of EKG interpretation to figure out really the why, because we're just looking at the rhythms. But if we look at, but in our patient assessment, we want to know why, right? So that blue is hard to read. One reason for bradycardias, okay, could be a heart block, and we'll get to these later, meaning that somewhere along this electrical pathway, there's a blockage, and it's a heart block, okay, which is going to change the way the EKG looks at. We're going to do heart blocks last, so that'll make more sense. So you can have a heart block. A bradycardia could also mean an increase in parasympathetic response. Remember, the sympathetic nervous system will speed the heart rate up. Parasympathetic nervous system will slow the heart rate down. So this bradycardia could be from an increased parasympathetic response. So you can get the opposite from a tachycardia, right? An increased sympathetic response. So a reason for a tachycardia would be an increased sympathetic response. When you get down to the medicine part of it, both of these, a severe tachycardia and a severe bradycardia, will decrease what? Cardiac output. Very good. Which would decrease oxygen to the tissues. So if you had someone with a severe bradycardia that had a decreased cardiac output, what would be one sign that you could see, that you would recognize as a decrease in cardiac output?
Oxygen.
Well, okay. Late sign, cyanosis. What about an early sign? Very early sign.
Is there the oxygen? But would it be like short of breath?
Has nothing to do with oxygen.
Short of breath.
Well, yeah, I guess it does have to do with oxygen. Never mind. It's a hypoxia where? Which would give you what? There you go. Altered mental status. So you're going to get with the decrease on both sides. A tachycardia is going to decrease refilling time, which is going to decrease cardiac output. A bradycardia is going to decrease cardiac output. So both of them could give you an altered mental status. That will take place relatively quick. Okay, so that's what we want to find out. Okay, especially before the heart stops, right? Slower, stop. That's what we don't want. Fast. Too fast, it stops. It overworks itself. The heart's going to stop. So these are the things that we want to sort of look at when we have a bradycardia. We'll talk about these ventricular escape rhythms. They're like below 40, sometimes only in the 20s. They're not enough to perfuse, okay, to keep the patient conscious. They're just enough to sort of a last-ditch effort. We definitely want to find out why the patient has a heart rate of 30, right? Before we started CPR, because that's very close. Heart rate of 30, you need to crack your knuckles and get ready. Stretch your back a little bit. You're about to do compressions. If they don't fix it. Heart rate of 30, it's when seconds count. You need to fix that right now. or you're going to have a dead person with you. You're going to be doing CPR. Right? So anyway, these could be a valve problem. I think that's what he was drawing here. A tachycardia could cause a valve problem. You see a lot of that with your energy drinks that you guys drink. They destroy these heart valves. You got to be very careful with those. Okay. When we get back to blocks, we'll come back to the bradycardias. Most heart blocks are bradycardic. Okay. Tachycardia, you have some sort of increase in the pacemaker stimulus. So your SA node is increased. SA dysfunction could be it. I mean, there's a lot of reasons for a tachycardia. Dehydration, okay, increased sympathetic tone for some reason. You know, so you have to sort of start running these through your mind. It's like, how can I stop it? A severe tachycardia above 150, then you definitely want to figure out how to stop that. When you get to 150, 180, that's in that SVT range, so the cardiac output is going to drop drastically. Then we have these re-entry conduction problems, okay? AFib, VTAC. Remember, paroxysmal is where it comes and goes, okay? Like the SVT, PSVT, paroxysmal tachycardia, right? And we're about to talk about WPW, okay? We won't spend much time there, but we will talk about that, all right? So, as you look at the bradycardias and tachycardias, think about, okay, why? Why is that, right? Why do we have it? And sort of run down through your checklist, patient care-wise. And then this is a different, it's the cardiac cycle. We'll talk about this right quick because I don't really want you to memorize too much on this cardiac cycle, all right, other than what they said in the video. Keep in mind here, and you've seen this in the hospital, you've seen this, EKG, right? But other places you've seen these waveforms, okay? So if you're in the SICU and they may be doing some hemodynamic monitoring, okay, with the certain catheters, like a Swan-Ganz or something like that, or a catheter that's in the artery, it's going to produce, SpO2 produces a waveform, right? Produces that pleth. All right? You can tell that that's correct when the waveform is correct, once you learn how to read the waveforms. Fortunately for you guys, we're not going to learn how to read these different waveforms in cardiac. The cardiac cycle, okay, the atrium make a certain waveform, the ventricles make a certain waveform. It's really cool. If you go into critical care medicine, like the ICU or something like that, if you're going to be a cardiologist, you will learn hemodynamics, okay? I used to teach it to critical care paramedics, flight medics. It's really cool. You can tell a lot. Like you can do a Swan-Ganz catheter. You can go in there and do what's called a pulmonary capillary wedge. You blow up a little balloon in a pulmonary capillary where the distal end of this catheter is, and it gives you an electronic look at the left ventricle. So if this pulmonary capillary pressure is high, it means something. If it's low, it means something. Okay? Not only that, you can go in there and you can place a pacemaker in that. You can place a thermometer where you have a constant temperature. You can do cardiac outputs. I've done it a couple of times just to say that I've done it. And you push fluid in there and it reads it and it gives you a cardiac output. Okay? When you're in the SICU, maybe shop around. Ask, do we have someone that just went through open heart? Because they'll probably have a Swan-Ganz in. Okay? It would be rare, but not like at Baylor, but it would be rare there, you know. I mean, they're like, oh yeah, you want to see Swan-Ganz? Come over. We have 5 of them. Because they have a cardiac ICU. So all the heart patients go to one place. It is neat. It is neat to do the hemodynamics, but they measure these cycles and they measure these things. Are the atrium working? Are the ventricles working? And they're all with different pressures and waveforms. And you just memorize the waveform the same way that you're doing with EKG and the rules of interpretation, the different pressures. And so when you see these, you're able to tell. That's why, like blood pressure, don't really need to look at peripheral blood pressure when you have an arc line that's being that they have a catheter in. I lost the word. That's being transduced. Okay, when you transduce the arc line, you have an arterial pressure, and it's constant. All you have to do is look up at the monitor. You could look up there and see the mean arterial pressure. That's been a while since we talked about that. But who cares about a peripheral pressure when you have a mean arterial pressure? And who cares about any of that when you have an arc line in there and looking at arterial pressure, right? But you can just look at these waveforms like, okay, like one waveform here, you can't really see it, but there's a notch there. That notch has to be in there because that's telling you the valves are closing. Okay, so every little, just like the EKG, every little bump and notch means something once you start interpreting these waveforms. But fortunately, we're not going to go into that. What I want you to remember here, something that you already know, cardiac output equals stroke volume. What is stroke volume?
It's the amount in the ventricles after it fills and pumps out.
Now, not the amount in, that's in diastolic pressure. The amount that pumps out. So with every contraction, the amount of blood that is pumped out is stroke volume. Okay? So every time that left ventricle contracts, I know there's different, we're using 70 as our standard, but a normal stroke volume is 70. So that ventricle contracts, it ejects 70 milliliters if that's the norm. Okay? Heart rate, we got that down, right? So we multiply those two together and we get cardiac output. What's the normal cardiac output?
35. No.
Yeah. It's in liters. 5, yeah, about 5-6 liters per minute. Okay? Very good. And then something we talked about when we talked about congestive heart failure was ejection fraction. Remember that? These guys who have this big heart and it's all stretched out. Starling's law still, right? A little review there. That heart stretched out because of congestive heart failure. And we measure ejection fraction. That is the percent of blood that is ejected from the ventricle. Okay? Anybody remember the normal ejection fraction?
55.
You go, 55, good. 55% ejection fraction. These guys that are dying from congestive heart failure, some of them have like 15, 10%. 10% ejection fraction, you couldn't walk across the room. You'd have to stop like every few steps. Okay? So they measure that ejection fraction. That is very important. This is 4 to 8, so we can go 4 to 8 liters. Normal cardiac output. Okay? Just remember the definitions there. Then in blue you can't see it, but syncope. Below 30. The patient passes out. They pass out, why?
Because they're not having.
Right, they don't have enough oxygen. Very good. They lack oxygen, so they pass out. They'll get that altered mental status first, and then they'll pass out. It just depends on the rate. You know, so you fix this. So if you had that severe bradycardia, okay, and the patient has an altered mental status, how would you fix it? Simply, how would you fix it? You could raise the heart rate, right? Figure a way to raise the heart rate, and that's what we haven't talked about. We haven't talked about it. How do you raise that heart rate? Okay. I'll go ahead and give it to you since you but it's just in case you see it in the hospital. They might give a drug called atropine. Atropine. In short, atropine produces more P waves. It affects the SA node, so it's going to speed up. It speeds up the heart rate. They could give epinephrine, 1 to 10,000, different solution than what you're used to with the allergic reaction. That's a 1 to 1,000 solution. Not a big deal. Just know that they could give epi as well. If it's a pediatric patient, they're going to give epi, not atropine. Okay? An old person like me, they'll probably give some atropine. So if I had that heart rate of 30, they may give me 0.5 milligrams of atropine to speed my heart rate up. In that crisis moment, okay, of when I'm walking towards the light with that rate of 30 to 25 to 30 heart rate, right? The ER doctor's going to come in and say, give him some atropine. Let's get that heart rate up. Okay? IV. These both are administered IV. So that atropine's going to hit the heart and it's going to increase that heart rate. The other way, something that we haven't learned yet with severe bradycardia, and I can't remember which class actually saw it. It was in, we had this problem. They started pacing the patient. They put the EKG pads on, like the defibrillation pad, and they paced the patient. So they turned on the cardiac monitor to pacer, and they had electrical signals going through the chest wall to the heart to pace it, to speed it up. You heard of a pacemaker, right? Mm-hmm. Okay. Well, it's the same thing. It's an external pacemaker. It's sending electrical signals to speed up the heart. The problem is with the pacer, external pacing, okay, does it capture? That's the term. Does this pacer capture? If it captures, then you're going to have a pulse that is associated with that signal. So every time it sends a signal, ever how many times, you're going to have a pulse with it. Sometimes it just doesn't capture. So like in someone that has, they may be in cardiogenic shock, their heart rate's real slow, they're about to code, they're trying to pace them, it's just not going to capture. Okay? The way that they do it is they turn it up in millivolts. So they start at a certain millivolts, like 80 millivolts. And if it won't capture, then they keep turning up the millivolts to a certain point until it captures to like 100, let's say, hypothetically. To 100 millivolts, and it won't capture. The way that they can tell that it captures, there's two things. Mechanical capture means that it will produce a pulse. Okay? Electrical capture that you see on the EKG, so when the QRS complex widens out and you have a little pacemaker spec, it has electrical pulse that matches that. Okay? So anyway, so that's the bradycardia, but these two medications that we haven't talked about. So the severe bradycardia, they're going to do this quick.
Okay, so why would the pediatric get epi? And why would
the pediatrics respond better to epi? An old man, they respond okay. They respond to epi, but you risk giving them a heart attack at the same time. Okay. Epinephrine and norepinephrine, like we talked about with the sympathetic nervous system, it's essentially the same. It does the same thing. Okay, so it's to increase that automaticity in stimulation of that cell electrically.
What would happen if a kid they were to give atropine to the pediatrics?
Oh, you can give atropine to pediatrics.
Oh.
They just respond better to epi. It won't hurt them. The dosages are different, obviously, but it won't hurt them necessarily. So there's ways to speed up, ways to slow down the heart rate, right? If we had a severe tachycardia, the same thing. How do we slow that thing down? How do we slow that rhythm down? Okay, that tachycardia. Yeah. Okay, it depends on what rhythm it is, and that's what we'll talk about here in a minute. When we talk about the EKG, we're only going to look at a couple rhythms on the EKG, okay, side of it. So we need to slow it down. So we give some medication to slow it down, okay. We could shock it and slow it down, that synchronized cardioversion that we talked about. We could do that. We could shock it that way. Or give a beta blocker to block the beta responses. Remember the beta responses? Beta 1? Beta 1 response is going to increase the heart. We block that receptor site with medication and it slows the heart rate down. So we can give that. You know, we can give that medication to do that. Good? Okay. This is definitely where we're going to stop here. Alright, so let's take a quick break and we'll look at some EKG rhythm.